Good day, my name is Ali Jawad. I'm a fellow in hand surgery and I'll be talking about our experience managing patients with brachial plexopathy following treatment for coronavirus. I work at the Queen Elizabeth Hospital in Birmingham in the United Kingdom, which in addition to being a major trauma and military medical centre, houses Europe's largest intensive care floor. During the first wave of the pandemic it was surge expanded to over double its capacity. This was to accommodate over 80 COVID admissions a month, each staying for over 2 weeks on average. It led to a rapid accumulation of unwell patients, typically escalated for ventilation, as around 40% would develop ARDS. It was then that prone positioning became widely used to optimize oxygenation, with proven survival benefit. Meanwhile, our peripheral nerve service began receiving referrals of patients who, despite surviving intensive care, had developed dysfunctional limbs. These patients typically presented with asymmetrical weakness, wasting, and prominently pain. In this example of a 51-year-old gentleman, you can observe wasting in his volar arm and forearm muscles with loss of elbow and digital flexion, but with a preserved brachioradialis. This clinically represents musculocutaneous and median nerve palsies, indicative of medial and lateral cord injuries. It was evident that these patients may have suffered brachial plexus injury during their admission. We therefore sought to explore these presentations in order to better recognize them and provide recommendations to aid the clinical teams caring for them, while conducting ongoing surveillance of these patients to help develop our practice. We formulated a physiotherapist-led referral pathway, comprising a triage tool to help identify extremity neuropathies. Their dysfunction would then be localized and graded, whereby higher grades would merit review by a peripheral nerve surgeon, while low-grade injuries would be monitored and only escalated if it progresses or persists. From over 250 patients admitted to ITU during the first wave, 96 survived to discharge. Of those referred to us, 15 were diagnosed with high upper limb neuropathies involving 30 dysfunctional nerves. Most presented with high-grade injuries, and all suffered from neuropathic pain and dense weakness with positive Tinel's signs. Interestingly, none exhibited signs of autonomic dysfunction, suggesting a prolonged compression rather than traction injury may be causative. They also incurred longer intensive care admissions than other COVID patients, between 20 and 60 days, and underwent more prone positioning overall. Finally, most patients were over 50 years old, and almost all suffered from cardiovascular comorbidities, with over half being obese. If we look at the distribution of palsies, we can see that the ulnar nerve was the most commonly affected, followed by the cords of the brachial plexus. These are susceptible to traction and compression from positioning, and we suspect that many had suffered broader infraclavicular plexus injuries which had partly resolved at time of review. We have since published this first case series, and our recommendations in minimizing injury from malpositioning implemented as a new standard of practice, also supplementing those published by Quick and Brown in 2020 and the National Guidelines on Proning by the Faculty of Intensive Care Medicine and the Intensive Care Society in 2019. The importance of care and precision in proning has been stressed in our standards, focusing on optimal head and neck alignment, and in light of the high prevalence of ulnar nerve and lateral cord injuries, elbow and shoulder positioning within the confines of the bed space. Our next step was to support the clinical teams, emphasizing vigilance in recognizing neuropathy and timely escalation to the peripheral nerve team, so that early rehabilitation can commence alongside both staff and patient education regarding safe positioning and avoiding pressure points. Finally, there are other possibilities that can complicate our diagnosis, including critical care myopathy, which typically presents as a diffuse symmetrical flaccid weakness, and other central and peripheral neuropathies. So, we are compiling a growing database of patients aiming to explore injury patterns and contributing factors, the results of our own measures, the influence of neuroinflammatory mechanisms, and the role of novel treatments such as immune-modulating medication. To summarize, we have identified numerous severe brachial plexopathies in COVID patients who required intensive care and are focused on optimizing proning to eliminate a potential underlying cause. We hope to progress our understanding of these presentations and through our ongoing research, develop a reliable means of diagnosing and managing these, aiming to improve post-COVID recovery. Thank you very much.